Ultrasound guide trochanteric bursa injection. Pain physicians always call the entity trochanteric bursa or bursitis, and I think is much better called the greater trochanteric pain syndrome. I just want to draw the analogy between the two conditions in the shoulder and the hip. The tendon of interest in the shoulder is supraspinatus, maybe with some other rotator cuff. The tendon of interest in this hip situation will be the gluteus medius and minimus. Yes, they are covered by the subacromial bursa or subgluteus maximum bursa respectively, but in shoulder we don't call it subacromial bursitis. We call it rotator cuff disease, and the same token apply here in the hip. We should just call it greater trochanteric pain syndrome. There's a lot of anatomical similarity here. Both tendons at each side attached to here in the shoulder greater tuberosity and here at greater trochanter. And they rub against the acromion in the shoulder or coracoacromial arch, while in the hip it rub against the fascia lata and iliotibial band. All right, so the greater trochanter is not just one piece of bone. It had 4 facets. We have the anterior facet, and this is the area where the gluteus minimus tendon attach. We have the lateral facet and then the posterior facet. The gluteus medius tendon attach mainly in the lateral facet, but send a sleeve or sling to the superior posterior facet. And the posterior facet has no tendon attached, but is covered by the gluteus maximus. This is important. It's covered but not attached to this facet. All right, now there is some article even talk about this 13 bursa around the trochanteric area, but I think the most important bursa we talk about is deep to that fascia lata or gluteus maximus, because subgluteus maximus bursa. Here, this is anterior, this posterior. If you flip the gluteus maximus open, and you can see a different bursa here, but functionally, I did the injection study. Functionally, it basically just behaves as one bursa. And this is the bursa that people would like to inject, and we call it subgluteus maximus bursa. Now, having said that, there is also a bursa over the gluteus minimus, and this is the bursa over gluteus minimus can be involved in the disease when the gluteus minimus have a tendinopathy or a small tear. Now, when you perform the ultrasound scan, the first thing to do is to find the ridge that divide the anterior facet and the lateral facet. In the anterior facet, you can see there is a gluteus minimus tendon, and the lateral facet you have the gluteus medius tendon. Here is the fascia lata. Is a very clear structure, white, black, white, and then between the fascia lata and the tendon, you can see there's a hypoechoic space. This is where the bursa is supposed to be. The bursa is supposed to be. So your area, your needle, the target of injection should be directed into this space, just superficial to the gluteus minimus and medius tendon. I'm going to show you the video here, and this anterior, the lateral or posterior is a posterior direction and with the lateral facet. The first thing to do is to identify the ridge, which is here. Once you identify the ridge, then you know this anterior facet and this lateral facet. And here, this is the beautiful tensor fascia lata, and this is the gluteus minimus tendon. And you actually should do a little bit better scan until you see the, okay, beautiful. So this, the hypoechoic space deep to the fascia lata, and this hypoechoic space is the bursa over the gluteus minimus. And when you perform an injection over the gluteus minimus, and that's actually where the target is. So I just want to draw attention here. All right, so this is the target. And then we go to the lateral facet. Lateral facet, again, we see the fascia lata, and this is a beautiful hypoechoic space between the fascia lata and gluteus medius tendon. Now, it's very clear here, so I just want to draw the attention. There's some more structure. This is the lateral facet, and turn around here, this is the posterior facet. And this is a big muscle, is a gluteus maximus muscle. It sends fiber attached to the fascia lata. And this is the interface between the medius tendon and the fascia lata, and this is your target supposed to be. Sometimes you may not see this fairly well, and you just continue the tilting, and here you go. And tilting, you can see it really well. Or there's another method you can do, is to do the long axis scan. Means actually you align the probe along the long axis of the gluteus medius tendon, and here is. So beautiful. So again, it's the same fascia lata. This is the head, this is the foot, this is trochanter, and this actually is the whole thing is a gluteus medius tendon attached to the trochanter. And again, you find a bursal space here, and this is where your target is. All right, so it's actually, so far we find the sonal anatomy. The next thing is to perform the injection. You put a needle implant from posterior to anterior for the gluteus minimus. Again, you find the interface between the fascia lata and the gluteus minimus tendon, and you inject over superficial to the gluteus minimus. And for the gluteus medius, the same. And again, this anterior is posterior. I changed the orientation, sorry. And you see the fascia lata, gluteus maximus muscle, and this is the gluteus medius tendon, and this is a bursal space, and you put a needle over the surface of the gluteus medius tendon. And sometimes if you want to see in a long axis because of some difficulty in seeing the structure, you can do this. Again, it's very beautiful. There's a head, foot, fascia lata, gluteus medius tendon. Again, this is the potential space that you can go for. A lot of those information have been summarized in this review article that I published 5 years ago. And one of the questions people want to know is, do I need the ultrasound? What about if you inject with a landmark guided technique? We performed the only study that validated the landmark guided technique, how accurate it is compared with the ultrasound. We find that landmark guided technique is not too bad. You actually get 2/3 chance, it means 66% or 67% into the target over the surface of the gluteus medius tendon. But if you want to be close to 100%, then you use ultrasound guided. But I think there's a few situations that certainly ultrasound guided injection will be highly indicated. First, when someone have a failure of response to previous landmark guided injection, I think is pretty reasonable to give the patient a better chance to use a ultrasound guided injection. Or when you try to perform the injection, but you cannot find a landmark, the patient have just a high BMI, I think is again pick up your ultrasound and perform an ultrasound guided injection. For some reason, if you just know the pathology from the imaging report, and you know the major disease is mainly in the gluteus minimus, I suggest you not to do it landmark guided because the gluteus minimus is very hard to palpate, is fairly deep. And lastly, I think the major indication for ultrasound is when you want to perform fenestration. Well, why do you want to have a fenestration? Well, think about this. If you have a patient who have tendinopathy, not the tear is tendinopathy, which is an intrinsic disease of the tendon. And no matter how much you inject on the surface of the tendon, it won't touch the disease. So in this case, you need to put the needle multiple times into the tendon, and you much better to have a ultrasound to guide you. This is much I want to say about the GTPS injection. Thank you very much.